All right, good evening. Hope you guys had a good weekend. The picture in my story was from the Chesterfield Air Show yesterday. So saw the Blue Angels, and for those that have been following me for a while, some of you know I was in the Navy quite a while ago. I was an internist for Naval Hospital Beaufort, taking care of the Marine recruits at Parris Island. So saw the Blue Angels documentary on Amazon the other week. Thought it was awesome, and realized they were going to be in St. Louis this past weekend, so went out there and saw it and got some good pictures. So that's what that was. So got a lot of good questions tonight. We'll answer them in due order. If you have some that weren't submitted ahead of time, you can just drop them in these comments, and I'll get to them if we have time at the end of the half hour. So I usually go from 6 to 6:30 Central Standard Time every single Monday. For those that don't know me, I'm Dr. Twyman. I'm a board-certified cardiologist. I help people not have heart attacks. Is how I kind of simplify what I do. I own the Apollo Cardiology, and my team helps me with screening people up, looking at all the risk factors for vascular disease and helping them eliminate those as best we can. So do start this out. This is not direct medical advice. I can't answer your medical question to tell you to start or stop any supplementary medication unless you're actually one of my patients. But I can kind of educate you on some of the things you should be discussing with your own doctors if I'm not that person. So we'll answer a lot of the questions tonight, and we'll get started. What are the recommendations for a slightly high TSH with thalassemia trait? So if your thyroid stimulating hormone is over 2, then you may have issues with subclinical hypothyroidism. So I would look at free T3 levels first to confirm that. Excuse me. But if you have thalassemia trait, I don't think that's necessarily going to be playing a role with the thyroid. I'm not in that area of expertise. But I would think about the thalassemia trait, how it's going to affect your hemoglobin A1C. Often it'll give you a falsely high hemoglobin A1C because your red blood cells may last longer than the usual 90 days. Next question up tonight. Somebody says that they recently had extensive blood work and their TMAO level came back elevated. What's my reaction to this number? And viewpoint on TMAO being a precursor to heart disease. So trimethylamine oxide is produced in the gut as a byproduct of carnitine and choline metabolism. It's actually created in the liver. High TMAO levels associated with dysfunctional HDL and vascular inflammation. So it's a potential risk factor for vascular disease. I look at more of a marker of gut health than anything. I don't think people should eliminate seafood from their diets if their TMAO levels are high. But if you're supplementing with carnitine and your TMAO levels are high, you probably want to come back on the carnitine supplement. So I would look at it more as a marker, is your gut healthy? So, I'm not a GI doctor by any means. So, if you're not having regular bowel movements, then start with the low-hanging fruit there, and potentially work on your circadian biology if your gut is not optimized, because your gut microbiome is initially programmed by the light that strikes your skin, not by probiotics. Question about salt. Can too much salt be detrimental to heart health? Yes, but not in everybody. The glycocalyx, which lines your arteries, it's the protective gel coating in the 60,000 miles of blood vessels you got. One of its jobs is to buffer the sodium load. But if there's other things that are disrupting your glycocalyx, such as high insulin, infections, heavy metals, plastics, then it may not take that much salt to further disrupt the glycocalyx. So not everybody's sensitive. There are different SNPs where people are more sensitive. You could do a Vibrant America panel that looks at the cardiac X, 25 different genes, and you would know if you're more a salt-sensitive individual. Typically, people who are sensitive, they're going to have more issues with their blood pressure increasing with higher salt loads, and or they will have swelling in their extremities. Question, do I know much about coronary artery vasospasm or microvascular disease? Yes, I do. This is my area of expertise. So it is endothelial dysfunction until proven otherwise. So if your glycocalyx is disrupted and you have endothelial dysfunction and low nitric oxide, that is the contributor to microvascular disease. 99% of your blood vessels is supplied by the microcirculation. So many women have more coronary artery vasospasms as they go through menopause and they lose the vasodilating effects of estrogen. But if you get particular testing that looks at your arterial elasticity, you'll know if you're more at risk for this. So this is where tests such as the max pulse wave velocity test, which tells you how elastic the arteries are, helps. The EndoPET test, which tells you exactly how much nitric oxide your arteries release when there's a vascular stressor. And your optimal result in that type of test is your arteries should triple or quadruple in size. Those would be starting points for that. And then blood work, excuse me, would be looking at ADMA, STMA. If those are high, those are lowering nitric oxide. If homocysteine is high, that will potentially lower nitric oxide, as will uric acid. High uric acid disrupts the glycocalyx and affects that. So definitely one of my areas of expertise. Test, don't guess is what you probably heard me talk about before. So you need to figure out what is causing it and improve it. There are different nitric oxide promoting supplements. There's glycocalyx promoting supplements. And then there's various pharmaceutical agents, including calcium channel blockers and long-acting nitrates if need be. Question, what is the best diet for cardiac and overall health? I'll give 2 takes on it. One, there is no perfect diet. It depends on your mitochondria. Your mitochondria would break down the foodstuffs that you eat into electrons and protons. So it depends on how healthy your colony of mitochondria are. If you have your haplotype from a 23andMe, that gives you an idea what diet might work best for you. Then it depends on your latitude. Where do you live in the world? Do you have seasons? What foods do you have access to that are actually, appropriate to your environment? Food that's shipped in halfway around the world is not necessarily the best type of food for you because it has a different photosynthetic blueprint than what your skin and eyes are sensing. So that is the long-winded way to say about it, that there's no perfect diet. It depends on your mitochondria, and then it depends on your goals. Second would be that if you want to know the one that has the most data behind it, if you're just generalizing, typically it's going to be either a Mediterranean type of diet or a DASH diet, the dietary approach to stop hypertension. So those are good templates if you want to research those as well. Somebody asks, how can they tell if they're insulin sensitive or resistant through recent blood work that they've had? It would depend on what labs are done, but your fasting insulin should be less than 8. Your HOMO-IR score should be less than 2. If you don't have access to that, you would roughly know if your hemoglobin A1C is less than 5.1, triglycerides less than 80, small dense LDL are low, VLDLs are low, then you're likely insulin sensitive. But you need to look at insulin and HOMO-IR if those were not obtained. What are my thoughts on IV ozone benefits versus risk? Recently tried it for COVID, seemed to help. That is one of the indications for it. IV ozone is more beneficial for infections, autoimmune conditions than anything else. I've not seen any significant data supporting that it has a lot of benefit for cardiovascular disease. So I actually had some dental work done today, and the dentists use ozone often. So they used just a syringe full of ozone gas to basically ozonate an area to make sure that no bacteria were growing in the area before they sealed off an area in my mouth today. So never had IV ozone myself. I have some colleagues in St. Louis that are experts in it. Generally relatively safe, but you do want to work out there with somebody who knows what they're doing with it. But mostly useful if people have like chronic disease, mold conditions. That's where I see the most benefit. All right, and I see one of my big supporters on here, Drew, just logged on just a minute ago. So welcome, Drew. I did a really in-depth podcast with him about a month ago. So that was my 2-part deep dive with him. I did one about a year and a half ago. We went over his Clearly and some of the Boston Heart Lab results at that time. And the newest one was more updated, talking about microplastics and carotid artery disease. And then he had some family members come into my practice at Apollo Cardiology, and we screened up them from head to toe, looking at their vascular health, their endothelial health, and did some genetic testing to figure out what they're dealing with to lower their risk of cardiovascular disease. Next question up tonight is, are some people more sensitive to COVID based off blood type? That's not necessarily my area of expertise. It is my understanding that blood types tended to have worse outcomes, but from a vascular standpoint, the people who are more susceptible are people who have endothelial dysfunction. If your lining of your arteries is already disrupted for whatever reason, and some resistance, microplastics, toxins, then the spike proteins from COVID have easier access to binding to the ACE2 receptors that is underlining the glycocalyx. So people with endothelial dysfunction, high blood pressure, diabetes, they're more at risk because they basically pulled down their force field into their lining of their arteries. So that's what I would consider. And then thoughts on prevention: do everything you can to improve nitric oxide availability. Can't change your blood type. All right, I think next question is about somebody's there's either a CT angio or a cath report, but they're reporting that they have, and this must be a medical person, by the way, that they're abbreviating, but I'll spell it out in English. So they have mild beginning part of their left main artery plaque. They have mild diffuse plaque in their left anterior descending artery and the beginning part of the artery. And then their right coronary artery and their circumflex has mild disease. What are the thoughts? Well, we need more context, but you have triple vessel disease. How old are you? If you're 80 years old and this is your findings, not too bad. You're probably not going to go down the path where you need stents or bypass surgery. But if you're 35 years old, then that may be an issue. In the past year, I've had a couple of people less than 40 years old that have had heart attacks, or they've had stents placed before they come to see me, and we're doing the deep dives to figure out what happened. Why do they have events under the age of 40? So age is the biggest risk factor, but what is driving it? I would want to know this. So could you, do things that look at your nitric oxide availability? Those are the tests that, we talked about earlier, the max pulse, the pulse wave velocity testing, the CIMT, the carotid intimal medial thickness scan tells you how thick the lining of the arteries are. Do you have soft plaque in the arteries? And then you have access to it. There's other testing that blood work can look at, different genes. So it takes a kind of a deep dive to figure out why do you have the plaque. But I usually kind of break it down to three big buckets: things that affect nitric oxide, things that affect oxidation and inflammation, and the third bucket is the lipoproteins. What is your ApoB? What is your lipoprotein little a? So I see an add-on question here. What is the minimal viable dose and optimal dose for red light? So it's really going to depend on what is the area of treatment and what type of device the person has. So photobiomodulation, using light therapy to change your biology, was first basically discovered in the 1960s by an Austrian researcher. They're actually doing cancer research with red ruby lasers in rats. They're actually trying to induce cancers in these rats, and what happened when they used the lasers is that they actually grew the fur back on the rats, and that was a big surprise to them. They did not induce cancer with it. The research is mostly going to be hidden behind the Cold War, during the Cold War, because a lot of it was in Russia. Eventually, the research did get translated, and then NASA picked up the baton and did a lot of the research in the 90s and was able to actually develop some LED technology that was compatible with using it for photobiomodulation. So there are a couple variables that people have to look at. One is the wavelength. What color of light are they utilizing? Often there's going to be a combination of red and infrared light. So the red spectrums, it's going to be something that's going to be in nanometers. So a common red one will be 660 nanometers. There will often be an infrared wavelength, which you cannot see, but your body will absorb, and that is 810 nanometers. So first you got to have the right colors. Variable two is you have to have the right irradiance or power density. This is measured in something called milliwatts per centimeter squared. So you'll see various companies, saying that their device is super powerful and it's 100 milliwatts per centimeter squared. That is probably overkill for most people. You don't need that many power density. It's not like, it's kind of like cooking a turkey with a blowtorch. You don't need that much light. So probably the milliwatts per centimeter squared that most people should be looking for is probably between 12 and 20 milliwatts per centimeter squared. That's what a lot of the full body beds studies had indicated. And then the timing, well, it depends on what area is actually being irradiated, but for most full body sessions, 12 minutes or less is kind of what they were seeing the most benefit from. Now, how often? Depends if it's acute injury. If it's acute injury, it's pretty much a daily session. If it's kind of more maintenance, probably 2 or 3 full body sessions a week would be kind of maintenance. If nothing is hurting, usually I recommend people kind of focus on their sternum. There's mesenchymal stem cells that are in the sternum, and they get activated. Then the stem cells go out and do what they need to do. Long-winded answer about my thoughts on current red light therapy. Next question of tonight. What is the top recommendation for recovery following a heart attack and stent placement? So this is actually backed by a lot of science, and it's not that sexy of an answer. It's cardiac rehab. Cardiac rehab has so much data behind it at reducing the risk of recurrent events and reduce the risk of dying than anything else, even more than the medications that they gave you after the stent. So definitely would recommend doing cardiac rehab. After cardiac rehab, then it's figuring out why did this event happen. So that's the deep dive. Do you still have endothelial dysfunction? Do you still have a lot of inflammation? And then, depending on what they started, usually if you were on lipoprotein management going in, they may have altered it coming out. Well, is it working for you? Where is your ApoB after treatment? For somebody who's recently had a heart attack and stent placement, generally your ApoB probably should be less than 70, and ideally probably less than 55, so that you stop doing damage to the artery lining, and then the body can do some repair work. So those would be the top recommendations: is try to figure out what caused it, and definitely do cardiac rehab if you haven't already signed up for it or had your doctor sign you up for it. And I think that there's some follow-up information about it. It was for somebody who was in their 80s who had that event. So, all right, next question. It looks like a list of some supplements and medications. So I don't know exactly what the question is because I don't know what the context, but berberine, arterisol, garlic, Wizetia. Or is it overkill? If so, is one better over the other Wizetia? So let's just go through them, what they are and why you might not be using. But I can't give you recommendations to start or stop any of these things. You have to talk to the person who recommended them to you. But berberine is a supplement, can have an effect on glucose, kind of like metformin, so it helps you with your blood sugar regulation. But berberine is also a weak oral PCSK9 inhibitor, meaning it helps your body clear cholesterol particles from the bloodstream. So you've heard in my previous talks about lipids, I often use a tennis ball as an analogy for a lipoprotein. Well, berberine helps with the receptors that would grab the tennis balls out of the circulation. Arterisol is a glycocalyx promoter. It basically helps regrow the gel coat in the lining of the arteries. So think of it as like it helps the force field in your arteries so that less of the cholesterol particles, less of the white blood cells stick there in the first place. Garlic, most likely this should be more specific. It should be chyloic aged garlic because that's what was actually utilized in the studies. Now it's great to have garlic in your foods, but it's a standardized dose in the studies that help show plaque stabilization and actually calcium score tests getting better. So chyloic garlic, pretty much for anybody who's got plaque in either the carotid or coronary arteries. And then Zetia, or its generic name ezetimibe, it's what's known as a cholesterol reabsorption inhibitor. It blocks cholesterol from being recycled in the gut. So I've used the analogy I did use on Drew's podcast. Think of cholesterol as water, and it's going into a bathtub. The way to prevent the water from overflowing is you can either go in there, shut off the faucet. That's utilizing a statin or Nexletol, so less cholesterol is being produced, less lipoproteins are made in the liver, less of them going through the bloodstream. You can pull the drain plug. That's using things like berberine. It's very weak, but it does help a little bit. Or the injectables, that's Repatha, Praluent, and there's another one called Leqvio. Those are PCSK9 inhibitors. They open up the drain, the water comes out, and then once water's in the drain, you got to make sure it actually goes out to the sewer, and that's what ezetimibe does. Without ezetimibe, some people have a block in the sewer, and then the water just basically backs up into the bathtub. It doesn't really, but it basically goes back through the portal circulation to the liver. That's the nerdy way to say it. But ezetimibe makes sure that if the cholesterol is destined to leave the body, it actually does leave the body. Now, I have some patients that are on all that cocktail. I've had patients who are on part of it, so it does depend. But there's nothing in between them that has a supplement or a supplement drug interaction that I'm aware of. All right. What is my top recommendations to improve endothelial lining health, if any? Of course, I got some. So, it's going to be exercise. It's going to be sunlight, particularly the UVA spectrum of sunlight. It's going to help liberate nitric oxide from the arterial lining. Green leafy vegetables, things that are high in nitrates, are going to be beneficial for it. But often, a lot of things are removing the things doing the damage. So, I assume you're not smoking or vaping. Microplastics, what I talked about on that podcast recently. So, drink out of glass or steel. So, don't drink out of plastic bottles. Don't, drink tap water. You want to process your water so you're not putting toxins into the system. Those are probably the starting points. And then there's a whole host of different supplements that can kind of support the lining if there's damage that's occurring. Now, ultrasound question. Somebody says that their echocardiogram, which is an ultrasound of the heart, shows mild left atrial enlargement. And then it says /TTR, is it reversible? So the left atrium is the chamber in the heart that receives the blood from the lungs after it's been oxygenated. Then the blood goes through the mitral valve down to the left ventricle. The left atrium is very thin, and if there's high pressures in the left atrium, it will stretch out like a balloon and sometimes not go back down. The larger your left atrium, the more risk of atrial arrhythmias, such as atrial fibrillation. The larger left atrium, the more risk of other heart rhythm issues. But think of the left atrium as almost like your hemoglobin A1C. That's your 90-day average blood sugar. The left atrial size is this measurement of the pressures inside the left atrium. Now, I'm not sure what TTR truly stands for. I don't know if you're trying to say that you have cardiac amyloidosis. That's getting to be a more common condition. I don't currently have any patients with it that I'm aware of, so it's not necessarily something I'm well versed in, like what are the best treatments. I was actually at the ACC meeting, the American College of Cardiology meeting in April, and there's various vendors out there that have new drugs that are targeted towards TTR, if that's the condition you're talking about. But that also could stand for trivial tricuspid regurgitation, which is a valve on the right side of the heart and wouldn't affect the left atrium. So I'm not quite sure what TTR stands for in this, but is left atrial enlargement reversible? Yes, if your systolic pressures are controlled, your diastolic function is controlled, it is potentially improvable. Somebody's talking about the cholesterol balance test. This is a test that is available either on Boston Heart Diagnostics, or there is a home version called Empower DX. It's a stick your finger, drip blood onto a card, and then you mail it in. But the short is that they actually mail it into Boston Heart, and then they do the analysis on it. This person saying that the test didn't give them a score, and all the numbers lean towards hyperabsorber. And then they say, Zetia question mark. So the test doesn't necessarily give you a score. There's 4 variables on it. The top 2 are markers of cholesterol production. Those are lanthosterol and desmosterol. Those are compounds that are produced in the liver. They get broken down into cholesterol. And then the 2 bottom values on it are markers of hyperabsorption. So that's beta-sitosterol and composterol. So it's color-coded. So there's a green, yellow, and red. So if everything's in the green zone, well, you're neither a hyperproducer or hyperabsorber. So if your ApoB is under 70, great, good for you. If it's not, then it's more an issue with your LDL receptor. It doesn't work very well. Your LDL receptor is supposed to be plucking these particles out of circulation. Maybe you just don't have that many off-ramps to get the particles out of circulation is how I would look at that. So I wouldn't necessarily worry about the score. It's just, is it green, yellow, or red? But if everything is in the green, okay. But if things are more in the red zone and it's all towards the hyperabsorption of beta-sitosterol and composterol, then you can make dietary interventions. You could try to cut back on saturated fat to less than 8% of your calories and see does that have an effect on it. But if your numbers are still not improving, then ezetimibe is something to consider. It's a cholesterol reabsorption inhibitor, closes the gate, prevents the sterols from being reabsorbed. Question about premature ventricular contractions. Can they go away on its own? Yes, but ideally try to figure out what's causing them. Sometimes it's electrolytes, so low potassium or magnesium. Sometimes it's an overactive thyroid. Sometimes it's these devices that we use. The closer your devices are to your heart, the more likely the heart myocytes are going to be impacted by the EMFs. And I've seen many patients have PVCs just because they keep their phone in their pocket, or they have their Apple Watch on that's not in airplane mode. The second they stop having the EMFs near them, their PVCs go away. Can my friend improve a coronary calcium score of 1,000? It sort of depends on what you mean by improve. I always think about it more as a test to risk stratify individuals. So a calcium score of 1,000 is a very high risk score. Better shot than not that one of the arteries are going to have severe plaque in it, and potentially even stenotic, meaning enough restriction in the flow that there be ischemia during a stress test, or the person may have symptoms such as chest pain or shortness of breath with physical activity. Now, the first goal is to figure out why the score is so high. Can you improve the endothelial function? Can you lower the inflammation? Can you treat the lipoproteins? Do the treatments. But can the calcium score go back to zero? No, I've never seen it go all the way back to zero. Can it stabilize? Absolutely. But the trick is that once you have a calcium score that high, there's really no reason to ever repeat it again. So you would never really test it to see does it go down. You just want to start treating the person because they're very high risk. So think about this. If you treated them and the score went down, you wouldn't stop the treatment. And it doesn't mean they're necessarily getting better, because you need to know that you're treating plaque that you can't see on that calcium score test. So it's a good starting point, but if you really want to know, are you getting better, you have to do a CT angiogram, and that requires an IV with contrast. There's more radiation, and if you want to, you can add on the Clearly analysis. Adds more cost, but it's more sensitive at looking at the plaque characteristics. So it'll tell you how much low density plaque, how much soft plaque, and how much hard plaque you have. That will really tell you, is things recovering? And this is not peer reviewed. This is my N of 1, but my recent Clearly scan, when I repeated it, the soft plaque shrank by approximately 6% in 2 years. Now, this was done in an experiment for myself where I was improving my endothelium and my glycocalyx, and I wasn't using any pharmaceutical agents at that time to do that. Very interesting, N of 1 experience. But I'm going to start having more and more patients repeat their Clearlys because I've been doing this scan for 3 years. Now I know the appropriate time frame is probably 2-ish years after having your initial one. If you want to repeat it, then you would know that there's enough time that passed that you could see the plaque improving. Question about omega-3 supplementation. I do it on occasion for patients. I don't personally supplement it. I try to get it through dietary intake. It is always better to get through dietary intake. It's more likely to be in the SN2 position for the quantum biology people following this Q&A. Once you start supplementing something, you introduce variables that you may not be able to control. So will I do it on occasion? Yes, but not for everybody. And you want to use good vendors that are made in high quality factories. So most of the time, Carlson's or Nordic Natural, the better two over-the-counter brands. There may be others, but that's the risk. There's a lot of bad actors in that field. If you get a poor quality product that's already rancid or oxidized, you may be doing more harm than good because your body then has to detoxify from the oxidized oils. So I would say use a high quality product, and you can do testing to see where your levels are at. So I generally will shoot for an omega-3 fatty acid index, greater than 5.5%, depending on which lab you're using. But if you don't have access to that, you can look at the ratios. Generally, should have a kind of 4-to-1 omega-6 to omega-3 ratio or less. That helps keep inflammation under control. All right. I don't know if this is the other person's test, but it says that follow-up 64-year-old female with no family history of coronary disease, diabetes, hypertension. Their total cholesterol on a traditional panel was like in the 140s, LDL cholesterol in the 70s, and ApoB looks like, can't see on the screen here very well, looks like maybe 62 or 82, can't see for sure. Do they need a calcium score? So I look at calcium scores as basically like a mammogram. It's a screening test. And I think pretty much anybody over the age of 40 who hasn't had one should consider one. If you've already had an event, you have a heart attack, stroke, stent, bypass, there's no reason to get it. But I used to have a kind of a standing order, like, if you're over 40, you should consider one. But I'm seeing more and more patients, in their mid-30s who've already had events. Not saying I necessarily could have prevented the events, but they may have known that they were high risk and they may have been more aggressive with their lifestyle, their supplements or medications, and potentially had a more chance to stabilize the plaques, or at least they would have known they're at high risk. The two people that I'd seen recently at the top of mind, they had very minimal risk factors before they had the events. One actually had a very bad type of heart attack and had fortunate good care, and now we're figuring out why he had that. And there's another gentleman who had a calcium score test that was very, very high for somebody who was in their mid-30s. So I think everybody should consider getting one, and if your score is 0, good for you. Keep doing what you're doing. But, if you live long enough, for the most part, your calcium score test will become positive. You just want it to be as light as possible, and you want to die with atherosclerosis. You don't want to die from atherosclerosis. So again, I can't give you exact medical advice unless you're my patient, but somebody's asking about, can you take multiple nitric oxide promoting supplements? You generally can't necessarily overdose yourself, but if you have low blood pressure to begin with, you potentially could get to a point where you're becoming lightheaded or dizzy. So I wouldn't double up on nitric oxide promoters unless you're working with somebody who made that recommendation based off of testing that you've had done, that you still have elevated central aortic blood pressures, you still have stiff arteries, you still have endothelial dysfunction on EndoPed, then you could consider those type of things. All right, so I think I got through all your pre-submitted questions. I saw a couple people popping up some comments, so I'll try to get to those and get you guys on your way this evening. But for those that are just joining, these are always recorded. It'll be in my archives here in just a moment, and then usually later in the week, this will be uploaded to my YouTube channel, which is just youtube.com at Dr. Twyman, spelled up like that above. And I will have the fancy AI machines, do a transcription and also, summarize the questions that are answered, so you can kind of try to skip ahead if you don't want to listen to the whole 30 minutes of me answering the questions. Somebody was giving some feedback about the TMAO. So if you eat a food that's high in TMAO, such as fish, and immediately go get your blood work, it's sometimes going to give you falsely elevated levels. So, I often, will only check TMAO, people are on supplemental carnitine, or there's a concern that there's going to be an issue with their gut microbiome, then I'll check it. But I'm not routinely checking it on every patient every single time. I may do it the first time I meet them, but not routinely. Let's just say interesting, because probiotics is not always the answer. Somebody's saying, is chest pressure something to worry about? They get a pain in the middle of their chest when inhaling. Is that bad? So again, I cannot give you direct medical advice if you're having active symptoms. You have to talk to your local doctors if you're having active symptoms. But anytime you're having any type of symptoms in your chest, you want to know, is that due to your heart? Cardiac chest pain can come in multiple forms. Cardiac angina, generally described as a pressure or squeezing or pressure sensation, typically occurs during exertion, as you outstrip the heart's demand for, or I should say, the heart's supply for oxygen and nutrients. It can also come when people are having significant emotional stressors. If it's happening more at rest and it's more pleuritic, then there could be inflammation on the outer side of the lungs, or you could have pericarditis. So wouldn't be able to tell you what exactly it is, but if it's bothersome to you enough, you should go get it checked out with your local doctor. Somebody's asking optimal cholesterol levels. I don't necessarily want to say cholesterol. I would say what are optimal lipoprotein levels, and it again depends on your vascular risk. Have you had prior events? But typically, ApoB under 70. If you're high risk, ApoB under 55. Somebody's asking about vitamin K2 for unblocking arteries. Doesn't have as strong data as it once was purported to, but vitamin K2 can have some benefit at helping keep calcium in your bones. So typically, you want to have optimal vitamin D levels in K2. It's not all magical without the vitamin D part as well. And it doesn't necessarily unblock arteries. It just helps stabilize the plaque, taking thin cap plaques that are more prone to rupture and stabilizing them. So think about more like a pimple that's red hot and inflamed on the artery wall, and you're trying to stabilize it before it ruptures. Let me just ask another red light question. Can you use it without clothes or not? So the light has to be, basically directed to the area of treatment. It's the mitochondria that are absorbing the red light for the most part. So the acronym is RATS, RATS. So red light or any photomodulation will do this. It will either reflect. So you've seen some of my prior videos where the room is lit up red. Most of that light, 60% of it's bouncing off your skin and going away. Some of it's absorbed. So the closer it is to your skin, the more the photons of light are absorbed. Like X-rays, they're transmitted through the body. Photomodulation doesn't transmit through the body, but some of it's scattered. The light goes in, bounces around, and eventually gets to the mitochondria. So closer is better for some devices. So if it's battery powered, it can be direct to skin contact. If it's plugged into the wall without knowing what device, generally want to be back 6 to 12 inches from the device to minimize EMF exposure from it. But you cannot use photomodulation through clothes because the clothes would block it. It would be like throwing a tarp over a plant and expecting the plant to grow, when the sunlight's striking the tarp instead of the plant. It's a very good question. And they actually do have a study that looked at this with a device called the MRI Plaque View. Somebody's asking about a product called, can the arterial supplement from Calroy help stabilize soft plaque in the carotid arteries? The answer is yes. The MRI Plaque View test had shown that the soft plaque had delipidated within 6 months. I don't off the top of my head remember the exact percentage, but it was somewhere impressive, somewhere probably like 30 to 40%. So very interesting. They're doing more studies to see if that will potentially be replicable in other vascular beds. I suspect it will be. Again, my end of one is that it definitely helped reduce my soft plaque, and I was on this product at that time. But I should give you a caveat, or just a disclaimer, is that at times I do some paid speaking for Calroy, do webinars for other doctors, and have talked at different conferences for them. But that doesn't bias me in my way of recommending them because they have other studies that have been done in humans that are been reproduced. And I've seen it time and time again in my own patients that their vascular health tends to improve on this product. So I don't have any problem recommending that product. I'm not quite sure what this question is asking, but can a cardiac catheterization be set up for no stents, only to survey blockages, to report back to patient to set up future intervention surgery if indicated? So, coronary angiogram is an invasive procedure, so it's not a risk-free procedure. So I don't recommend it for quote screening purposes. Typically, they're only done in cases where patients are having symptoms, they failed the stress test, or had a recent heart attack, and they're figuring out, what is the anatomy. And the cardiac catheterization isn't the best way to assess plaque. That would be more of a CT angiogram, particularly using clearly analysis, because you actually see the plaque in the walls of the artery. So, think about plaque is an iceberg, a cardiac catheterization. And I did hundreds of them when I was still an invasive radiologist. They're aluminum. You're just looking at the tip of the iceberg, how much of it's poking up over the surface of the ocean, and this including flow. If it includes flow more than 70%, then the interventionist will often, recommend, proceeding forward with a stent, or if there's multiple plaques that they can't fix with stents, then we'll talk about options for bypass surgery. So cardiac catheterizations are often used for staging. It doesn't mean you automatically get a stent every time you get a cardiac catheterization. So you need to know more details before considering undergoing that type of procedure. But there are other techniques that they can do in the cath lab. They can do FFR, they can do IVUS, they can interrogate the degrees of plaques and see if they're, amenable to coronary interventions. All right, take a couple more and we'll wrap it up tonight. So, what's the best diet for an aging female? Again, I'd probably go back to look at the the answer I did here earlier, it's going to depend on your mitochondrial haplotype. It's going to depend on your health goals. If you want a good template, a DASH diet or a Mediterranean diet is a good starting point. But you definitely have to make sure you focus on your high quality dietary protein, because as my friend Dr. Line talks about, you need to focus on muscle centric medicine. So healthy amounts of protein to help promote muscle growth is key. Can leaky heart valves cause arrhythmias? Yes, particularly mitral valve prolapse can definitely cause heart arrhythmia. Somebody says, how can I get an appointment to explain my case and get my opinion about what to do after the triple bypass surgery last October? Uh, they're in Portugal and they're 56 years old and have a very sporty life. So I have a practice in St. Louis, Missouri, Apollo Cardiology. I do work with patients from all over the country and some international clients. But for me to be able to prescribe or actually recommend anything, patients have to be physically seen in my office at least once, and then the follow-up visit can be done via telemedicine. Uh, my bandwidth doesn't allow me to do kind of educational consults at this time. So most time it has to be somebody coming in person. And if people are interested in that, they can go to my website. This is drtwyman.com. There's a button up at the top to apply to work with our team. And one of my team members will set up a Zoom call with you and make sure that we can help you with the issue that you're concerned about and can answer any questions you have about how to work with us. Question, can an Apple Watch or phone cause PVCs and PACs? Yes, I've seen it personally. I've seen it with patients. I've seen patients have other heart rhythm issues with them on, and when they stopped them or kept the devices in airplane mode, those type of heart rhythm issues went away. So you might have been seeing me kind of bounce around with the ring on. I'm wearing the Gen 3 Oura ring. I keep the thing in airplane mode the entire time. When I want the data, I take the ring off, download the data, and look at it. So they just released a feature the other week. I'm still waiting for my 14 days of data before I can get my results. But they released a feature with looked at pulse wave velocity, which is the arterial age, and it's also looking at your VO2 max that's assessed. So I'm going to look at that to see how accurate it is compared to some of the devices I have in my office. All right. So I know there's a lot of other good questions coming through tonight, but I usually try to keep it to 30 minutes because I don't want to overwhelm people, and I will use the time to um, you know answer more of the questions next Monday, 6 p.m. time. If you have a question, just submit it in the pre-submitted question ahead of time because I always answer those ones. And if there's added time, I will try to get to as many as I can in the comments. But I appreciate your guys' time and attention. We'll see you again next week.